We're on.
I'm going to present a study that was just recently accepted in the White Journal. The title of this study was to compare subjective ultrasound assessment and the ADNEX model with ultrasound-guided throughput biopsies to differentiate disseminated primary ovarian cancer from metastatic non-ovarian cancer. In this prospective study, we included 143 women with disseminated malignancy of unknown primarity with a pelvic tumor or pelvic carcinosis. These women, they were followed up for 6 to 43 months. At inclusion, we collected information on their patient history and tumor markers CA125, CEA, and CA99. All women underwent transvaginal and transrectal ultrasound, followed by transabdominal ultrasound, and then we performed throughput biopsy using the route that we thought was most feasible and less uncomfortable for the patient. The sonographic features were assessed according to the IOTA classification. We also looked for signs of necrosis because these features had previously been reported to be more common in metastatic tumors. We also searched the abdomen to look for metastases in the liver, in the omentum, and in the peritoneal cavity. The overall aim was to compare the subjective ultrasound assessment and to look at the ADNEX model compared to ultrasound-guided throughput biopsies to differentiate primary ovarian cancer from metastatic ovarian cancer. Oh, sorry. We used a BARD biopsy gun with a 6 to 19 gauge needle. We took 1 to 3 biopsies per patient. This procedure was very simple. There was no use of anesthesia or fasting, and women returned home 30 minutes after the procedure. We only used local anesthesia in case of using the transabdominal route. We did not regularly use any antibiotic prophylaxis, only in cases where we took the biopsies transrectally. The vast majority of biopsies could be performed transvaginally. A minority of the biopsies were performed transabdominally or transrectally. We used the ADNEX model to calculate the probability of a primary ovarian cancer or a metastatic non-ovarian tumor. The ADNEX model could only be applied to women with a clear ovarian lesion and with a conclusive diagnosis based on the throughput biopsy. We couldn't use the ADNEX app because in this series there was only 2 possible outcomes. So instead we calculated the risk according to a conditional risk calculation method. 2 women were in need of hospitalization after the biopsy. 1 woman using low molecular heparin got abdominal hematoma and pain, so she was admitted, and another woman returned back some days after the procedure with fever and pain, and there was a suspected infection. Both women returned home some days after the admission. There were no complications needing surgical intervention or blood transfusion. Some of the women had slight minor bleeding after puncture, but this always resolved if you just pushed on the bleeding site with a sponge. So we had no serious bleeding complications. A conclusive diagnosis was obtained from almost 90% of the women. In 8.4%, the pathologist could not make a conclusive diagnosis about the primarity, and in 3.5%, the biopsy was considered non-representative. Primary ovarian cancer was found in about 70% of the ladies, and metastatic cancer was found in 30% of the ladies. The most common metastatic tumors were colorectal cancer, gastric cancer, and breast cancer. Among these women with conclusive diagnosis, only 30 of them, in all 36 underwent cytoreductive surgery, and among those, 30 women had a conclusive diagnosis according to the TrueCut biopsy, and this diagnosis was confirmed in all cases according to surgery. We can move this forward. Here you see the demographic variables. Women with a metastatic non-ovarian cancer, they were younger. They more often had a history of a previous neoplasia. They had lower CA125 values, higher CEA and CA99, and they more often died during follow-up. After correction for multiple testing, the main associations, demographic variables differentiating primary ovarian cancer from metastatic cancer was age, CA125, and a previous history of neoplasia. In women with a history of previous malignancy, half of them had a recurrence of the previous cancer. The probability of recurrence was related to the type of previous malignancy. In women with a previous history of ovarian or colorectal cancer, around 80% had a recurrence of the previous malignancy, whereas women with a previous history of breast cancer, only 30% had a recurrence of their breast cancer and 70% had a new primary tumor rising from the ovary. These are the sonographic features that differed significantly in between primary ovarian cancer and non-ovarian metastatic cancer. Women with non-ovarian metastatic cancer, they more often had mobile tumor. The tumors more often had signs of necrosis. There were more often more than 10 locula. Whereas women with the primary ovarian cancer, they more often had pelvic carcinomatosis and an omental cake. After correction for multiple testing, the main associations differentiating primary ovarian cancer from metastatic ovarian cancer were the finding of mobile tumor and omental cake. Metastatic cancer had more often mobile tumors, and women with primary ovarian cancer more often had omental cake. Here you can see some examples of metastatic tumor. This is a pancreatic cancer. They are the only tumor that in my series could actually be purely multilocular at their first presentation. Then we have a Krukenberg tumor, which is a solid tumor arising as a metastasis from the ventricle. Other tumors that can be purely solid are, for example, breast cancer metastases. Colon cancer metastases are quite often large. They have signs of necrosis, and there is often both cystic and solid areas. In this perspective series, subjective ultrasound assessment had a sensitivity of 82% and a specificity of 70% to predict primary ovarian cancer in women with disseminated malignancy, with either a pelvic tumor or pelvic carcinosis. Here you can see the results of the ADNEX model. The ADNEX model performed really well. The area under the curve of the ADNEX model was 0.89. Using only CA125, the area under the curve was 0.83, and the cutoff was something around 300. It depends on what kind of sensitivity and specificity you're aiming for. And subjective assessment, you find it up here. And in these series, it was not possible to tell which of these strategies that was the best because the confidence intervals were too wide. Oh, sorry. See if I can move. So we feel that you can use either subjective ultrasound assessment, the ADNEX model, or CA125 to predict the probability of a metastatic non-ovarian tumor. And if you feel that there is a high risk of a metastatic tumor, you should proceed to a TrueCut biopsy. Since TrueCut biopsy is an excellent method, it will provide you with a conclusive diagnosis in almost 9 out of 10 women, and the frequency of complication is very low, despite the fact that these women were quite ill. Most of them were using low molecular heparin. There was a lot of thrombosis. They had high intercurrent disease. Despite this, there was really few complications. And the characteristic of women with metastatic non-ovarian cancer is that they are younger, they have lower levels of CA125, and they more often have a history of previous malignancy. However, in women with a previous history of breast cancer, it was quite interesting to find that in these women, it was actually more likely that they had a new primary tumor. Metastatic non-ovarian tumor were more often mobile, and mental cake was less often seen. Thank you. Any questions?
Any questions? Dirk? Oh, you haven't got a question. I see. Question at the front, if you got the microphone. Who's got the mics? Oh, okay. Question there, lady there, and then you. Okay, please.
Yes, thank you for your...
Yes,
thank you
hello.
for your excellent presentation. Did you actually use the ADNEX for decision making, or it was just part of the study? And do you advise in suspected metastatic tumors to always start with the TrueCut biopsy before any other investigation? I mean, looking for the primary.
I'm not sure if I got your questions right. The first was a question about the ADNEX model. We actually applied it after the completion of the study, so we didn't really use it to tailor treatment or anything. And we did it with a special computing, so we didn't really use the app. We had to especially calculate it because there was not like 5 possible outcomes, only 2, because we knew per se that these women had a disseminated malignancy. And the second question was...
You advise after the study that you should always start with a TrueCut biopsy in patients where you suspect that it is a metastatic? I mean, you don't start looking for the primary, you take a TrueCut first and then...
I mean, it has to do with what kind of resources you have. I mean, if the tumor is already disseminated, we don't need to think about the risk of disseminating anything. So either you can do it as a two-step strategy. You make a subjective assessment, you look at CA125, or you use the ADNEX model. And then you can, in those probably metastatic cancers, you proceed with a TrueCut biopsy. If you have the resources to do a TrueCut biopsy in all women, of course you can do it. It is a question of resources.
A question at the front, Antonia.
Elisabeth, congratulations. It's a quite impressive number of TrueCut biopsies. And I think that together with Daniela's experience, it's quite a unique experience because it's a sort of a comment, my intervention. Because in other oncological units, as in ours, we are not absolutely allowed to do that because they want to offer the patient a first step by laparoscopy or laparotomy, even if we see the tumor is already spread. So this is a comment first. The second one is this one. I saw some images from colorectal cancer metastases. They usually appear as multilocular.
Yes.
So do you feel confident to get a biopsy from those tumors? Because I suppose it's quite difficult in terms of representative biopsy because they are multilocular. And I know that from a pathological point of view, it's very difficult for them to differentiate according to one very small size of material.
I always try to get a good sample. Look, it's really important to scrutinize the pelvis and the abdominal cavity to see where you can most probably get the best solid tissue, and in a safe way, looking out for vessels and other things. So in a purely cystic tumor, it's difficult to take a biopsy because you cannot only puncture the capsula, but if you see carcinosis and if you have solid components in the tumor, you should go for those areas. But as you can see, 3.5% were non-representative, and this was more like multilocular cystic tumors, a majority of those. And also in some cases, like 8.5%, there was a good sample, but it was impossible for the pathologist to conclusively determine, despite they using sophisticated histochemical techniques, they could still not determine what kind of tumor it was. And also in some patients actually undergoing surgery, it was still difficult for the pathologist because it was such a low differentiated tumor. So it is not 100% conclusive. Sometimes it's not possible to get a good sample. Sometimes it's impossible for the pathologist. But the take-home message is still that in 9 out of 10 persons, it is possible to get a conclusive diagnosis.